Hey everyone, and welcome to This Explainer. Look, if you're a GP trainee right now, I know exactly what you're going through. The pressure of prepping for the AKT exam, it is absolutely massive. It feels like you've got this endless giant mountain of clinical protocols to memorize, and routine drug monitoring schedules are notoriously tricky. Examiners just love to test your recall on specific timelines and key lab parameters. But don't worry, I've got you covered. Today, we're going to transform all those dry protocol tables into a high-yield, structured study guide. We're going to take a ward-round approach, basically building patterns in your mind so that on exam day, you won't just be guessing, you'll know exactly what to look for.
All right, here's our game plan for today. We'll kick off with some essential exam prep, then move through cardiovascular, rheumatology, neuropsychiatric, and endocrine drug monitoring. Finally, we'll wrap up with a final review question.
Okay, let's dive right into Section 1, Essential Exam Prep, the ground rules.
Now, the absolutely crucial thing you have to keep in mind today is this. The tables and parameters we're covering are strictly basic safety guidelines. We are not talking about monitoring how effective a treatment is. A classic trap examiners love to set is confusing efficacy with safety. Like, you check lipids to see if a statin is actually working, right? But that's effectiveness. Today, we are laser-focused on key lab parameters for toxicity and safety. So, keep that mindset locked in for this whole explainer.
Moving right along to Section 2, Cardiovascular Drug Monitoring.
All right, I want to start by putting you on the spot a little bit, kind of simulating the pressure of the test. Imagine a patient is starting amiodarone. What 4 things do you absolutely need to check before they take their very first pill? Think about it for a second. Amiodarone is a seriously heavy-duty drug, and its baseline requirements definitely reflect that. Got your answer? Well, prior to treatment, you need a heavy-duty baseline, TFT, LFT, UND, and a CXR, a chest X-ray. All 4 are totally non-negotiable before treatment even starts. But here's the catch. Notice how much it simplifies once they're actually on it? For ongoing monitoring, you're literally just looking at TFT and LFT every 6 months. Examiners absolutely love to test if you know the difference between that intense baseline and the much simpler 6-month ongoing check.
Now, what's super interesting here is the contrast in scheduling between 2 incredibly common primary care drugs, statins and ACE inhibitors. For statins, your main focus is the LFT, and the schedule is super rigid, baseline at 3 months and at 12 months. But look at ACE inhibitors. Here, the main parameter is UNE. You check it prior to treatment, but the highly testable trigger, the one they will absolutely quiz you on, is checking UNE specifically after increasing the dose. And then, of course, at least annually. So please, don't let them trick you into applying a 3-month, 12-month statin rule to an ACE inhibitor. It happens all the time.
Next up, Section 3, Rheumatology Drug Monitoring.
Okay, we're kicking this section off with methotrexate, and I really want you to listen to this exact quote from the Committee on Safety of Medicines. They state, FBC and renal and LFTs before starting treatment, and repeated weekly until therapy stabilized. Thereafter, patients should be monitored every 2 to 3 months. I'm reading this to you word for word because these are rigid, completely non-negotiable rules in clinical practice, which means they are heavily examined.
Let's actually map this out on a timeline to build a really strong memory aid. Point 1, your baseline is FBC, LFT, and UNE, your renal function. Point 2, you check these weekly until the therapy is stabilized. And point 3, once stabilized, you shift right into the maintenance phase, checking every 2 to 3 months. Try to picture this exact timeline in your head when you're sitting in that exam hall.
This timeline is so crucial because examiners love to swap the weekly durations between methotrexate and azathioprine just to see if you're paying attention. Remember, methotrexate requires weekly monitoring until stabilized. Azathioprine, on the other hand, requires an FBC weekly strictly for the first 4 weeks. After that, azathioprine monitoring for SBC and LFT switches to every 3 months. So write this down, do not mix up until stabilized with the first 4 weeks. It's a classic trap.
All right, Section 4, Neuropsychiatric Drug Monitoring.
Time for another active recall prompt. Lithium is, without a doubt, one of the most rigorously monitored psychiatric drugs out there. Now, the overall main parameters for lithium are lithium levels, TFTs, and UNEs. But listen to my question very carefully. What parameters must be checked prior to treatment?
Okay, let's break down this split schedule. According to the protocol, prior to treatment, so your baseline, you check TFT and UNE. Then you start checking the lithium levels weekly until stabilized, and after that, every 3 months. But meanwhile, those organ function tests from your baseline, the TFT and UNE, are monitored every 6 months. Do you see what's happening there? The specific drug level is checked at completely different intervals than the organ function tests. This split schedule is just a massive, prime target for ACGK questions, so definitely commit it to memory.
Just briefly touching on sodium valproate. Your baseline before treatment requires both an LFT and an FBC. But for ongoing safety, the protocol literally just specifies checking the LFT periodically during the first 6 months. It's kind of less rigidly defined than lithium, I know, but remembering that specific 6-month window for periodic LFTs is absolutely key.
Moving to our last clinical stop, Section 5, Endocrine Drug Monitoring.
For the endocrine system, the protocol really highlights glitazones. And the requirement here is entirely liver-focused. You need an LFT before treatment, and then you've got to monitor the LFT regularly during treatment. Yeah, regularly is a somewhat vague word, but it is the exact essential guidance written in the protocol. Bottom line, if you see glitazones on the exam, think liver function.
And finally, Section 6, Final Review Question.
Listen, if you are feeling a bit overwhelmed right now by all these different blood tests and timelines, I completely get it. But consider this massive pattern. Think about statins, amiodarone, methotrexate, azathioprine, sodium valproate, and glitazones. What do they all have in common? Literally every single one of these drugs we discussed today requires baseline or ongoing liver function tests. It's all about the LFTs. So, if you're sitting there totally blanking on an exam question about a drug's safety parameters, betting that an LFT is involved is a statistically excellent choice.
I want to leave you with this thought. Yes, memorizing these incredibly specific schedules, like knowing to check UNAs after a dose increase for ACE inhibitors, or doing weekly FBCs for the first 4 weeks of azathioprine, sure, that's going to get you points on the AKT exam, but beyond just passing a test, mastering these exact timelines is how you prevent silent drug toxicity in your daily GP practice. These protocols exist for a reason. These drugs can quietly damage the liver, kidneys, or bone marrow without the patient feeling a single thing until it's way too late. So you aren't just memorizing for an exam, you are literally learning how to save lives. Keep studying hard, trust the structure, and I will catch you in the next explainer.